Toni, let me give you a few scenarios that I'd like you to comment on because we see them in the office. Patient presents with a primary tumor in place with metastatic disease. So your comments about cytoreductive nephrectomy in that setting. And then once the decision is made, after whether it's been active surveillance or the patient's developing symptoms, that you want to initiate therapy, what is your thought process for initiating therapy and the choice of agents in initiating therapy?
So the first question, I mean, going back as a patient present with, kidney in place, is this patient eligible for a cytoreductive nephrectomy? Usually I try, if they're eligible for cytoreductive nephrectomy, I try to get it out of the way. Initially, it does provide, in the appropriate clinical context, a survival benefit. I cannot say this is a level 1 evidence yet because there are trials ongoing. That may not actually answer the question, trials over 10 years slowly accruing that are ongoing, but at least if you look at retrospectively at large data set, retrospective studies as well as large national data set, there is a survival benefit from cytoreductive nephrectomy in patient with limited disease burden, good performance status, who can go to the operating room. So a lot of common sense. I try to get this out of the way, and it's important because you will get additional information from a kidney that is removed that you may not be able to get from a biopsy, especially if a fine needle aspiration is done that show you general renal cell carcinoma. So after that, and the patient is symptomatic, we need to start the treatment pretty quickly. I give usually around 2 weeks at least for the healing, sometimes more, especially if we have a clinical trial. And we start with a VEGF targeted therapy normally. Now our thought from now almost 10 years ago about using temsirolimus in patient with poor risk criteria. So at least patient that present with metastatic disease with kidney in place, they at least have one criteria, so they're at least intermediate. So one more will make you poor at least, or two more per the Hoodis criteria. But the problem is with this is that this is an intravenous infusion weekly that associated with a low response rate, where in the clinical trial the control arm was interferon. Retrospectively, several VEGF-targeted treatments showed efficacy actually in several subsets with poor risk disease. So if the patient is hospitalized, not doing well, you want to start the treatment, you want to start it fast, a quick prescription, then you start with temsirolimus. But if you're managing this patient outpatient, you have a time to start with an oral VEGF-targeted agent.
And just again to push you a little bit, Toni, so there are patients where primary tumor is there. Sometimes the extent of metastatic disease is greater than the volume of disease in the kidney. Sometimes the patient's symptoms are not from the primary tumor, but from their metastatic disease. I just want to be clear, are there populations of patients where you think an initiation of systemic therapy without cytoreductive nephrectomy is an acceptable approach?
Absolutely, absolutely. And those are the patients where you need to start systemic therapy and perhaps think about cytoreductive nephrectomy later. And sometimes, and especially if you get, usually with single agent, it's rare to have an amazing response in the primary, but we don't know. Perhaps with novel combination, we don't need any more cytoreductive nephrectomy. So absolutely, in this situation, systemic therapy is needed.
So Eric, we're faced with the patient that Toni just described. The patient's had their cytoreductive nephrectomy if appropriate. They've not had it if they think that their systemic disease requires systemic therapy first. And generally we think first about giving a VEGF receptor TKI, sunitinib or pazopanib. How do you make the choice? How do you modify the therapy? And what's been the experience at MD Anderson?
Yeah, so we have two really good agents, sunitinib and pazopanib, that are both very viable options. From an efficacy perspective, if you look at the phase 3 data, there really isn't a big difference. From a tolerability perspective, you look at the COMPARE study, and you look at the Pisces study, what we see is there clearly are differences in the types of toxicities that the two drugs provide. For example, sunitinib, probably more fatigue, more taste changes, more hand-foot syndrome. The pazopanib will cause hair changes, will cause transaminases. Nausea is something that's somewhat underreported, but definitely is a problem with that agent. So there are differences between the two. The equalizer, I think, for the two agents is how you give them. 4 weeks on and 2 weeks off is the standard schedule for sunitinib, but more and more in the community, people are using alternating schedules or changes from a 2-week to a 2-week on schedule or other type of schedule changes. And this type of insight into how to use these agents, I think, ends up making both drugs quite tolerable. In terms of personal experience, from the late 2000s when pazopanib became available, it was our mainstay for a while, but we're actually using, as we become more and more comfortable with sequence change, our schedule changes in sunitinib, we're using sunitinib more and more again. So it's kind of been interesting to see how our prescription patterns have changed. One of the other things is, there's further evolution of this, and there's an abstract at GeoASCO this year by Ornstein, where what they did is they did a lead-in of 4 cycles of sunitinib, and those individuals who had at least a 10% decrease in tumor burden were then actually allowed to have basically a break with re-imaging, where reinitiation of sunitinib would occur if there was a 10% regrowth. And this is a small study, but it's just an example of strategies that are being used which can mitigate toxicity. The goal here really is to keep people on a drug as long as possible with the least side effects. We have an abstract that's also submitted at GeoASCO, and what we showed, although our primary endpoint of grade 3 toxicities we were anticipating to reduce those to 15% or less, we still had 25%, but what we do see is that patients are staying on the drug longer, and we're having progression-free survival and overall survivals that are better than historic data. We don't know whether that's because of the strategy, but I do believe that knowing how to use these drugs keeps people on longer, and you can't have a response unless you're actually being treated with a drug.
Yeah, so Toni, I just wanted to push you a little bit, and the Ornstein abstract that also published in JCO suggesting of an intermittent approach. Do you think there's any evidence, or could there be evidence, that the development of resistance might be different if you give a drug and continue it versus intermittently give it? You have a lot of experience in prostate cancer and a different disease where people might think that intermittent blockade is superior to continuous blockade. Can you give me your thoughts about that?
There is actually preclinical data that is supportive, but actually the clinical data itself speaks against it. So there is a trial that is run by Ian Davis from Australia that, intermittently, based on the preclinical, does sequence sunitinib and everolimus back and forth, TOR and VEGF inhibitor that, did not show added toxicity. I would like to be, careful in this. I think any VEGF tyrosine kinase inhibitor, if you use it enough, familiar enough, you don't follow the resistor criteria well, you have a single arm study, you can use them and get your progression-free survival to be more prolonged. I think Eric and I and everyone here, we use the drugs really very well. That's what we do for a living. I think in the community, you cannot expect always the oncologist to have a clinic full of kidney cancer and to use sunitinib, pazopanib, cabozantinib, etc. as much. And perhaps this is one of the attractive things about using fixed dose schedule of drug like bevacizumab that are intravenous, like nivolumab and others. So I would say that there has been experience with sunitinib. There is experience with axitinib in dose escalation, but the problem is, where do you draw the line? And you can always keep the patient on as long as they're growing, not too quickly and they're not experiencing significant side effects, and your PFS can be prolonged. It's very important in this situation to have a control arm.